All right, so I got a couple of questions, and we can try and do them rapid fire or, just however long they take. But I kind of titled this part of the outline like best practices. We talked about like vessel sizing, and can you give like any more detail on like how many, like assuming like the vessel size is not a problem, like when is tortuosity, can you start thinking that this catheter's either not going to make the next turn or not going to get you in a position where you can be put to embolize? I know that's hard to put into words, but give it a go.
Of course. I think the easiest way to start that question is don't do what I did when I first started using the catheter. And this is like what I tell everyone as they're starting to begin to use the microvalve technology, is just choose easy cases. I chose the most tortuous artery I could have ever for my first case. And oh man, it was a painful experience. And I'm like, I'm never doing this again. And again, I was sold on pressure-directed delivery even before I took my case on. I think for your first case, it's always great to do either segmental, like a proximal segmental, or sectoral, or lobar delivery, because I think you're going to have a much easier time. Anything you're going to try and get super distal, if you're used to using like a TriSalus, for instance, you're not going to have that experience. None of these catheters are mimicking that. They just do too much to also be that dynamic, And so don't expect it to be that. And so start off with your, nice, easy wins. It's like what you tell your fellows as soon as they graduate, In your first year of practice, just choose the easy wins, Really build up your confidence and your skill set using these types of catheters, and then slowly start to expand it, right? So maybe start off with a lobar, do a few lobars, then go to a sectoral, and then you find that one where you're like, I really want to do a nice TACE, and like this guy's really decompensated, but I need to get distal. And then you choose that one for your distal one, and then kind of slowly build up your experience with tips and tricks on how to make these catheters get distal.
I tell you what, the scenario that you described to me that kind of resonated is like I've had plenty of treatments where it's like right at a bifurcation, and I park my in-hole catheter, but it just seems like the in-hole catheter wants to preferentially go towards the artery that I'm a little less interested in, or it's an artery that I want to treat, but I don't want 90% going in one. And so I'm always like, oh, I sure hope on the day of treatment it's either angled just slightly, because it just feels like that, like when you mentioned like the catheter like kind of centers itself, and then hopefully like the drug is like more evenly distributed between two branches. Base catheter considerations: use them with a Cobra, use it with a sauce, using like when do you have to change your base catheter, or any base catheter recommendations?
Yeah, of course. So I use a sauce for simplicity, that all my cases start with a sauce. I really like the reverse curve catheter of it, and I like that it's self-forming. So I always start with a sauce catheter. If I'm using the larger TriNav version of it, they have a sauce shape, and I'll just use that. So it's exactly the same shape as the sauce. If I need more purchase, I would probably switch over to like a Sim 1, or to really, I really just like reverse curves. And I know one of my partners and the person who trained me, Isabella Newton, always makes fun of me because she's like a Cobra out in the hepatic artery, and she always makes fun of my skills that I always am too nervous to do that, and I just use my little reverse curve catheters just in the celiac artery. But yeah, I think all of those have their benefits, and I just use a sauce because it's self-forming.
Okay. And as far as the lengths of your 5-French catheters, 65, 80 centimeters is going to be fine.
I do femoral for most of my cases, unless there's a reason to come radial for me. I just ergonomically, I've never figured out how to set up a room for radial, and I know others have figured it out. And hopefully, as we start building more of our new angio suites, we can make radial a little bit easier. But at least for me, ergonomically, femoral seems to work best. So I work in the 60, 65 range with 110 to 130 microcatheters.
Do they go 150 if you need them?
They do.
Okay. Can all embolics go through it? There's nothing that's off-limit. Liquid embolics, resin, glass, Lipidol, whatever.
Yeah, resin, glass, they all have the 020 inner diameter, and you're totally fine with both of those. Conventional TACE with Lipidol, use it all the time, and I've never run into issues.
Okay. Can you coil through it if you need to? I don't know if that ever comes up, but...
Yes. The inner diameter is fine. I can't say I've ever tried, because again, I usually start with the end hole and I'll do all my coiling first. Although, to be honest with you, I the amount of coiling cases that I do these days is pretty close to zero.
You already mentioned contrast dosing or contrast volumes and flow rates are the same. You did mention change your pressure
you have to change your pressure.
Okay.
I do that with all of my microcatheters. I think we, are a little complacent, we being all of us, where it's just like base catheter 600, microcatheter 750. And it's like in big black letters on every single catheter that you open what the pressure limit is. And since I've started using what they, the manufacturers that actually recommend you use, I get so much better pictures. And it's like a novel concept, right? Just do what the manufacturers ask you to do.
All right. That's a good tip.